We're very proud of the fact that we've been quite innovative here at Georgetown over the last couple of decades. This is good for women, good for patients, particularly good for women with breast cancer or the fear of getting breast cancer, because we've made the reconstructions better and better and better, and we've made the side effects less and less and less. So for example, we brought tissue reconstruction to Washington back in the early 80s with what we call the TRAM flap, which stands for the transverse rectus abdominis musculocutaneous flap, but it's taking your tummy, like we would for a tummy tuck, and making a breast out of that. So that's pretty exciting for women who've always wished they had a tummy tuck. Now they get a tummy tuck as part of a breast reconstruction. So that goes back 25 or more years. Then we brought to the area the prospect of doing that with microsurgery, where we don't have to take as much muscle. We can just take a blood vessel and do a tummy tuck, take the skin and fat from a tummy tuck and make that into a breast without taking much or any of the abdominal muscle. So that's very exciting. I think perhaps one of the most exciting things is the most recent thing, where we now do a lot of breast reconstruction where we don't remove any skin at all. This is called nipple-sparing mastectomy. It's not for every patient, but we do it for a lot of women when it's technically possible and when the state of the disease allows us to do it. We shell out the breast tissue, but we keep all the external appearance of the breast, and we replace the tissue we've removed either with an implant of appropriate size or the patient's own tissues. So to the outside world, it looks like nothing really happened, but inside, the breast has been removed and replaced with something that doesn't get cancer. So this is very exciting, and we do it every week now, and in fact 5 years ago we rarely did it, and today we probably do it on perhaps half of the women who have breast cancer that get a mastectomy at Georgetown. The likelihood of getting it back in the nipple in the patients that we choose to perform this operation on is very, very low. It's probably less than 1%. And if it does recur in the nipple, then you can remove the nipple. So we've been very happy with it. We've been tracking it very carefully, as have the other centers that are doing it. But so far, the accumulating evidence is that, in fact, if performed properly and on the right patient, it is a wonderful opportunity. And I can tell you, I've never seen happier women who've been treated for breast cancer than those who've had nipple-sparing mastectomies and reconstructions and come out of it looking as good or as beautiful as they started, and sometimes even a little better if that was their goal. If they wanted to enhance how they look, sometimes we can do that. So they feel like they got a little gift out of having to deal with their breast cancer, that at least to the appearance, that they look whole or better. Well, we're proud of the fact that we have a multidisciplinary team at Georgetown that can help guide a woman through the various options and decisions in terms of how to deal with the risk of breast cancer or the actual case of breast cancer. But more than that, frankly, it's not just that we have a team, a multidisciplinary team, but we're leaders in the field. I mean, if you look at the treatment of breast cancer nationally and internationally over the last decade or two, we've been out in front developing the latest techniques, both in terms of the diagnosis of breast cancer, the treatment of breast cancer, the reconstruction of the breast, and the medical oncology, the chemotherapy and other treatments. So, you know, we're leaders in this field, as well as having a full complement of people who can help you.